if it is. Yeah, we have the meeting is now recording. Okay, very well. This is the seventh session of the ELS program, and we are honored and we are happy that we have the chance to follow this path, and we have reached here by three special guest speakers from three different countries. And I'm honored to have the chance of meeting you here and to be hosting you as the moderator of this session. As you know, the title of this session is Managing Retreatment Challenges. We are going to see how you, as a skilled endodontist, manage your cases and how do you handle and face the hard situation or any actually challenges you may face in your daily practice. Thanks for accepting our invitation, and we are going to start this session. I think many of the audiences know you as the famous endodontist around the world. So I'm just asking the first speaker to give a brief introduction about himself and then start his presentation. Okay, Dr. Hassan, it's your turn and you can start your presentation. Thank you for accepting our invitation.
Good evening, everyone. Thanks you for the invitation, and I'm happy to introduce our seminars in the INLS project. It will be so great project, and in the future with many and also a lots of talented dentists with us. So we have a little time, so we must start our webinar. Everything is fine? Doctor, do you hear me?
Everything, yeah, everything is
Okay,
fine. Your voice is clear. Your the quality of your video and your slides are very perfect.
that's great. That's great. So the PowerPoint not change the slides. Okay, it's working now. As we know, retreatment is a large topic. We can handle it in one webinar, so we will give only the head topic of the retreatment and the mishaps that we are facing. So in general, this page will collect all the mishaps that we are facing in retreatment cases. We will start at the coronal axis. The coronal axis, if example, if we faced a patient with a bridge or a crown, what is the best options to remove the bridge or by drilling through the bridge directly? What's the best option for the dentist and for the patient? Also, we will face missed canals, fillers material removal, post removal, metal post, fiber post, broken instruments, blocks, and blades, transportation, and perforation. So, as you can see, there is a lot of mishaps we are facing. So we must have a good armamentarium and experience to manage them correctly. Okay, so we will start at the first case. Our first case, as you can see, tooth number 25, upper right 4 with separated file, 3 separated file. One of them outside the apex completely, as you can see, the little one, and the second one, the longest one at the mesiobuccal, that's inside the canal and part of it outside the canal, and the third one in the mesiolingual. What's the best option to manage such cases? And how to manage such a case? We have really three options, not two. The first one is obturate at that level and follow up. I don't like that. We can do our best, and we can do the surgery, and we can do the non-surgical retreatment. We have three options. For me, I will go with the non-surgical retreatment, especially if the patient is medically compromised. So I will go with that option. For file outside the Apex, uh, how we can treat it, how we can manage it. For me, I will go with the XP shaper. As we know, it's called tornado effect by uh, by using the XP shaper with 20 or 2000 RPM and go outside only 1 millim, we will can catch the file outside the apex. It's like tornado by holding the instrument from the outside to the inside, and it will be easy if there is part of the instrument inside the canal. And there is article by Dr. Suhail Kumar. You can check it later, talking about that topic. Let's start the video. There is important step to managing these cases by placing the by placing the irrigation not to the level of the orifice but to fill the chamber. Okay, and I prefer EDTA. Let's complete the video. As you can see, I go outside the apex, nearly 1 millim outside, not a lot. And trying three picking motion, then giving a rest to check if the file go out. And as you can see, the file is now out. It's easy. What do you think, Dr. Ali? Dr. Ali,
It
are
was,
you still with
it
me?
was, yeah. It was very good. But I want to ask my question at the end of your presentation. I have some question, but
Okay.
I will wait. Yeah, I prefer to
Okay.
wait.
Okay. I prefer to stay with me and doing more discussion because sometimes I'm afraid the connection is cut off.
Don't worry about that. I'm checking the connection. I will check the voice
Yeah.
during the session. Don't worry about that. I'm focusing on that. You just focus on your presentation.
Okay, okay, no problem. As you can remember the case before we start, let's go. That's three separated file and one of them outside the apex completely. That's what we get. That's what we get after remove the file. There is one outside and the second one at the mesiobuccal or the mesiolingual, sorry. So now we can obturate correctly. We can obturate, we can bypass the file at the mesiobuccal and obturate at the mesiolingual and obturate the canal, the patent canal at the of the mesiobuccal. The file before removing it was breaking the seal of the canal. So we can also leave it, but it will break the seal. So now we can obturate with the MTA with the easiest way by using the gutta percha as a plugger and cut it before the working length 4 millim, 5 millim, and by injection, as you can see this video, by injection the material MTA putty. You can use any MTA putty and placing the syringe of the acid H directly to the tip or to the syringe and injected it to the canal. Then packing by gutta percha. I prefer it more easily than using metal pluggers by using custom-made plugger from gutta percha. Everything was fine, but I added a lot of material and packed them, so I get a lot of sealer buff or MTA buff. My second case is lower left 7. Retreatment case. It's referred case from a colleague that did normal composite restoration, but the patient is still in pain, so he opened the tooth and did RCT, and the patient returned with pain also. The pain didn't go, so he decided to retreat the tooth again, but unfortunately, he separated files, three separated files, one of them with the apex, as you can see, and one of them at the coronal part, and the third one at the mesiobuccal. So he referred the case to me. I retrieved the first one easily by using BTR pen. It was easy peasy lemon squeezy. But what about the second one, the mesiolingual? Really, it was so hard. Okay, that's the first one. In retreatment cases, before I start, I prefer to use solvent material at the coronal part only for 30 seconds only, not more than washing it, only to make the coronal part of the guttapercha more soft. Or I can use the heat carrier by melting the guttapercha at the coronal part to make it easily bath for introducing the files and removing the guttapercha in one piece. If not, I will remove the guttapercha. I will, before I starting taking working length by the X-ray and reduce from that working length maybe 3 to 4 millim and introducing my file to remove the guttapercha. Maybe it come in one pieces or sometimes not. If there's remaining guttapercha at the apical part, I will use H file to remove it to prevent guttapercha extrusion outside the apex. But in this case, I make a disaster. During removal of the guttapercha from the distal canal, I pushed it outside. Now we are working at the mesiolingual. The files was highly engaged really, so I used a glide path file to making a space. You can making space at the inner wall of the file to remove it by using ultrasonic or by using the file directly. Okay, it's another method. If you can handling the file and putting it at the inner wall after making the space, at the first making a space with the ultrasonic file, then enlarging it by using the files. Sorry, ultrasonic tip, not ultrasonic files. Now I am using a TFRK loop. I prefer it more than PTR pen really because the loop, the wire of this loop is entering through lateral circle, not through the canal or not through the needle. So we can use it more than one time. If you failed catching the file, you can use it again and again and again. For the third file, I also retrieved it by using BTR. It was so easily, and it come with the Kotebercha in one piece. So this is H file separated because the wrong movement of the previous dentist just using the H file with not much winding motion, just twisting it, twisting it, twisting. So it will reach, how can I say it? It will reach point that will break easily. Okay, that's the third one. For the distal canal that I make disaster with it, as you can see, the mesial canals was patent. For the distal canal, I just pushed Cotepercha outside the apex. So What's sorry, sorry. So how I can retrieve it? So what's the problem if it's Gutenberg go outside the apex? It's just via inert material. It will not cause any problem. It's like the file. The file also will not cause any problem. It will not, the case will not fail. But the problem is that Gutenberg and that file is breaking the seal. Will not have three-dimension or hermetic seal, and it's a successful requirement for getting good RCT. As you can see, let's complete the video. We have a three option by using XP Shaper, and retrieve the Gutenberg, but really it's so aggressive because it's go outside. It will enlarge the apical foramen, and we have no choice only to operate with MTA, and also the XP Shaper will taking from the inner wall of the canal, not taking equally from all sides of the canal. So we will make a disaster. Also, we can use a TFRK GPR. It's like the arrow, and like the arrow that we can pull the Gutenberg with it by going outside and pulling inside, or by using H file break the end of the file and go outside with making 30 100 degree of movement and pulling it. Okay. Then I completed the case by injecting MTA directly into the canal and pack it with the custom-made gutta For the mesolingual, I just inject the sealer. For the mesobuccal, I just inject MTA and packet it with the gutta. Okay, that's MTA block, as you can see, in very easiest way. Then complete the obturation with the snowplow technique by injection the sealer and the gutta together. As you can see, we have lateral canals. We have two different portal of exit, and we have follow-up for this case. It's about 6 months. So now that's the final result. But really, I checked and diagnosed all the patient teeth, and was a little pain and discomfort from this tooth. Uh, but the real cause of pain is that tooth, the same side, the lower right five. The previous dentist just did many restoration for the 7, 6, and 5. So the pain start after that step. So he failed to diagnose the tooth and open the 7 endodontically, but really it was just reversible pulpitis, not irreversible. So I called the dentist and told him the cause it's not the 7, it's just the 5. You must recomposite the tooth and everything will be fine. And that's what happened. So, my favorite endodontic armamentarium for retreatment cases, TFRK loop. As I told you, I prefer it more than BTR loop, because it's less costly and you can use the tip many times. And TFRK, me, it's a sharp probe. You can use it to pull the cataperca or moving the file until making it dancing. Also, the TFRK GPR, it's if you see, it's the end of the probe like the arrow. So it will help you to pulling the gutta from the wall or into the gutta that outside the apex. And for the ultrasonic tip, that's TFRK 27, 28, and 29. It's amazing tip, amazing tool to use. For retreatment, there is, as you know, files designed for retreatment, but I don't use it. I just using the normal files. As you know, there is Martinistic effect and osteotonic. For retreatment, I prefer files that's at the middle or just near the osteotonic phase. It's flexible, but it's at the same time fixed. Also, you can use solvent, but I don't prefer solvent really because you will just missing and solvent the gutta percha that entering the dentinal tubule, making it more difficult to retreat. Maybe there's a biofilm that entering the dentinal tubule, and it will be a disaster. So I prefer to leaving the solvent at the end before the irrigation protocol to removing any remnant of the gutta percha by just placing solvent for 1 or 3 minutes using a paper point by weaving action of the paper point to removing the remnant of the gutta percha. So I don't use solvent, only at the last step before the irrigation protocol to be sure there is no remnant of gutta percha. And thank you for listening.
Okay, thank you very much. It was very interesting cases, and I really enjoyed your presentation. The video you shared
Thanks a lot.
was very impressive. I've learned a lot by your presentation. I'm impressed by your skills
No,
about managing
it's
your
thank
cases. It's
you.
very
Thank you so
good.
much. Thank you so
Thank
much,
you.
Doctor.
As long as we have passed about half an hour, I prefer to ask my questions and also Dr. Allen and Dr. Atto's question from each other at the end of the presentation. I just want to thank Dr. Hassan for his presentation, and I will ask Dr. Allen to start his presentation. Dr. Allen, do I spell your name correctly? It's Allen, yeah?
Yes, correct. Yeah, it's fine like that. Don't worry.
Okay, thank you.
All right. Is it possible to see the presentation now?
For me, not yet. Let me check why I don't have. Maybe it was my connection problem later. Dr. Hassan, did you stop your sharing?
Okay, I will stop the sharing. Give me a second.
Because I have the Dr. Allen presentation on my phone, but I don't have his presentation on my laptop. I want to have it on my laptop because I'm recording the session on my laptop.
So I cut off the sharing, doctor. I'm not sharing now.
You're not sharing? Okay. Maybe it is my problem.
Give me
I
a
can still
second.
see Dr. Hassan's screen.
Okay, okay.
Yeah, I think we got it. You're there.
Okay, please share your screen again. I think we will have it. Yeah, it's okay. Thank you. Yeah, very good.
But all right. As I was presented, my name is Raul Hernandez. I am from Mexico. I'm from the city of Tijuana. We're at all the way up north of the country, where the country starts. It's a pleasure to be here with you, to be considered. We must be doing some noise if we're starting to get along with such great voices like as yourselves. I'm very pleased to be here, and I'll show you some of my cases. I hope they're as good as our doctors, and hopefully we can learn something from each other as I've learned a lot from Dr. Hassan. Let me see if I can get this started. We're a city of multiple colors. We have ups and downs like everyone, but we have tons of variety and tons of color that we can share with you. This is my first case. I always like to start with this case because it's left me with a lot of learning. It is an upper 7, and as you can see, there's a lot of things going on this case. Before this, I would like to start. We all know that the main cause is bacterial damage to all the cases. But I would also like to remember that we also are treating patients, and we're also endodontists, but we were first made dentists. So we have to see our patient as a whole and not just a tooth, even if we don't treat other symptoms. This is my patient, Evelyn. She's willing to share everything with us. And she came with swelling, great case of pain, chewing, biting, TMJ, and just external and hard pain. So we decided to treat this number 7. We have this long and extended prosthetics. And before I started, we'd like to share this article, which is the classification of oral facial pain. Why? Because I had to look into a lot of things that were wrong with her, not just her endodontic problems. And we're going to see a lot of things going on with her. One part that I would like to emphasize a lot is we're treating pain not as just endodontic pain. If we're not going to treat another type of pain, we at least have to know where it comes from. So it's really important to know where it's heading from. As I said, my patient has a lot of TMJ problems. Every time, and I do this as a rule, every time that I'm going to treat a tooth that has a fixed bridge, I also have to take one of the other sustaining tooth. Why? Because I have to see if they're parallel between each other, if there's any force being wrong with them. So I think that's not the case right now. I took a CBCT and we have some inflammation on the sinus, which that's also giving us some information. And it's one thing to see at the x-ray, but she comes with this. We have a lot of things going wrong here. She had her previous root canal done through her crown. It wasn't fully restored. We have a lot of grinding and a lot of adjusting on the premolar, which means it probably wasn't well adjusted and they just ground it down to fix the occlusion, which is also giving us trouble. And we see we have no gingival reliefs. So we have a lot of problems here. Occlusal, TMJ, gingival, and endodontic. We're also going to treat endodontics, but we have to be aware and let our patient know that it's a lot of things going on with her, This is a previous chart of all the things that are going through our journal, and we're treating a lot of things. She also suffers from mild facial pain. That is something that is not within our ranks, but it's well to know at least that we could derive to the proper doctor, okay? Because I'm sure all your patients come for you for pain, and you have to be the solution. Even if you're not a neurologist, they just think pain, well, the endodontist has to treat it, right? Because it's pain. So I think that we can all suffer and relate to this kind of situations, and we have to read more about general pain and not just endodontic or dental pain. We decide to remove the crown, her bridge, and this is the situation that we find, some big gingival inflammation as well. And we're gonna treat this as a non-surgical retreatment. And we are currently treating her for a full mouth rehab because we also have to correct her occlusion and her pains that are not endodontic, but she can relate it to something like that. This is what I found once I opened up. I believe presentation of your work is very important. This is not the dirtiest that I have found, but I know that we are not happy to find obturations like this if you were the referring dentist. Least happy, I am also a proud user of solvents, unlike Dr. Hassan, but I didn't have to use any type of solvents with this. I could almost remove the obturation by hand. So it's poorly obturated, and that lets me to believe it's probably poor irrigated. We have this type of situations. I always like to record when I'm just deobturated. We have small orifices. That means no large taper was used. I mean, I'm not in fight with that type of philosophy, but we also have to enlarge a little more once we're retreating, like it or not. This is the type of, at least this is my first time this has happened to me. I opened up, I deobturated, and I actually found the full palatal pulp still remaining on the canal. It appeared to be obturated, so that tells you, and that leads you to see white lines or white lies, because something that's obturated doesn't mean that it's cleaned and shaped. It was just filled. So add this to my patient's pain, add one more to her list. Even though we can classify this as previously treated, we can also think there was some small percentage of irreversible pulpitis there, because that was her pain. She felt the pain when I pulled it out, and it was an immediate relief. So this was an endodontist that treated this tooth, a well-renowned endodontist. So I know we're not perfect, and I know we can all make mistakes, but this is something that she visited him. Something's wrong. My tooth still hurts. And it never crossed someone's mind to, oh, maybe I left the whole pulp in there, you know? Our cone fittings. This is my favorite part of every treatment. Irrigation is my favorite part. I try to hurry up as much as I can to do the best instrumentation, which I also enjoy. But this is my Goldilocks area. I like to at least give a 10-minute irrigation process with lots of hypochlorite, and then I can know that I can finish. This is something that I maybe done through a lot of learning and changing. I first like to try my cones. If they fit, then that means I'm technically ready to obturate, then I can irrigate. Because it happened to me that I've done my final irrigation, I spent some time working in there, and then my cones don't fit. And then I have to re-instrument. So that slows me down. So I don't know if someone would agree with this, but I would like to do my irrigation once I fit my cones. And you can see the difference between one and another. Wider doesn't mean better. I'm aware of that. But in this case, I cannot be the one that leaves more pulp on this tooth. So I believe it's a better outcome. I like a lot Endoseal MTA from Marucci. I know Dr. Alaa is with Marucci, and I can fully endorse this material. And I also like to do these fillings on both buccal and mesial on first molars. I like to do the obturation, and I like to see if they merge into one. That lets me to know that my irrigation was also well done, and that it's gonna flow better, and sooner or later they're gonna join and do one big canal, you know? Same, I believe this result is a little bit better than the first one. Maybe I could have left it a little bit more aesthetic, but my main goal is to alleviate my pain, my patient's pain. I also believe that we left a better restoration and a better result than the first one. I'm not against thinner canals. I also like 04 taper, but I do believe that on a cone route, it's better to go wider, because they're usually merged into one, and maybe a larger taper is sometimes a little bit more convenient on this type of routes. Our patient is currently with temporaries, no more bridges, and she's on ortho. So we're fixing everything from occlusion to orthodontics, and the pain has gone down significantly. She still has episodes because she still has this myofascial pain. But if we can help her at least 20-30%, I mean, for her, it's a world. It's a world difference. So it's a good thing that we can treat this one. Maybe it's not as flashy as removing 3 broken files. I'm not that good at removing files, but I believe that we can treat the patient from a lot of angles. And this is my case number 2. This is a case that I was actually visiting in office, and I took the x-rays. It was a fellow dentist that said, I'm doing this treatment. A dental student, and he was about to place his post, and the professor in charge told me, I'm going to do the post filling space for you. The patient suddenly jumped, it hurts, we're going to stop, and we're going to see you somewhere else. Okay. So we have this initial x-ray, and I think that we can all agree it's a really large drilling that happened there. I mean, we can still work with that. We can do obturation and it should be fine. And we have an obviously extruded gutta percha. I was going to stop at this point, and I think that we can all agree that we could have just thought on working, I don't know, headstrong file and just pulling it out, retrieving it. We can even do it with rotary files, or we can use solvents and just try to dissolve it and pull it out. That would be like our most logical solution. Something in me jumped, and I decided to take one more x-ray, and how the paradigm shifts right now. On the first x-ray, we can actually believe that the gutta percha is through the apex, straight, and now we have a different inclination. So this leads me to, maybe it's not the apex where this is coming out from. The patient derives no pain. He's asymptomatic, but when he touches himself on the gingival area, he says, it's not pain, but I can feel something. So we did order a CT scan. We can see a deviation from the canal, that's obvious, but this is our surprise. So what's appeared to be a really simple case of just retrieving a file just shifted into this adventure that I would love to share with you. Obviously, well done perforation was done with high-speed instruments, a really straight perforation. And I would like to point out maybe these 2 areas right here that I did find out on the scan. We obviously have the extruded gutta percha, and we have this palatal lesion that I did find on the scan, which is not connected to the tooth, so it's not the apex that is causing this. So we're gonna leave a couple of attention to that. We have our original canal and our perforation. If you maybe would have brought just this slide, I would have said, wow, it's a 2 canals, central incisor. But we have all the information, and we're sure it's not that. We have that flying white spot, which is the gutta percha. It's straight in the tissue, and we have this heart-shaped lesion on the palate. So we obviously need histological studies, but heart-shaped lesion on the palate on upper incisors, it's mostly nasopalatal cyst. So we're gonna address that as well. We have that right to compare it. That's the size of the lesion of the palatal. It doesn't make any type of communication with the incisor. So we're gonna address this on a 2-stage combined treatment. First, I'll do a non-surgical retreatment to try and retake the origin of that original canal. and making a reparation on the perforation. And our second step would be to surgically remove that flying piece of gutta percha, and maybe doing an external reparation of the perforation if it wasn't properly done through the canal. Why did I opt to do a surgical removal and not try to remove it through the canal? We showed our patient that he has a lesion and that he has to properly remove that lesion. So that's why we took the liberty of, if he's going through a surgical procedure, let's do it a full surgical procedure and do it buccal and palatally. I mean, he's going to have a full flap, might as well use that. The hard part is we have a straight canal and a lateral perforation. So retaking this canal, we might think it's an easy task, but remember, we did have a perforation that kind of sealed that original canal with dentin. So kind of unblocking it is going to be a hard part, but these x-rays are going to maybe minimize the work that we did, because it took me more than 40 minutes to retake the original canal. I had to really ground down our buccal surface so I can actually bend a file and that I can actually reach the apex. And x-rays were also hard because I had to really give an orientation for me to actually see the real apex. So once I did the original canal, we did the full retreatment. And this is maybe something that in my head, I would like to think that I invented. I like to use what I call a gutta percha post. Once I file down and I have my canal fully instrumentated, I like to place my cone as if it were a post, and I like to inject my repairing material through the perforation, and I use this gutta percha to actually mold and respect the space of the canal so it doesn't get filled with this material. This material, Neil Putty, has a 15-minute setup, so I could do the reparation on that same appointment, and it gives us this result. So we have an obturated canal and a repaired perforation. We are ready for surgery. And we did a small incision on the buccal side, and we only did like a small reparation of the external perforation. And we were able to retrieve that piece of gutta percha. This picture, we did the palatal surgery first, so that's why he has already the stitches. And we can kind of see the result a little better from this situation. I think the result is better than what we carried on. And something that we have to do is we have to do the studies. And it was verified as a non-malignant lesion, but an isopalatal cyst was confirmed. So we do have to remove those. It's better to, or even the advantage that we had that we use CT scan, which would be mandatory, but we were able to detect something that if we would have just used x-rays, we would have never found. And then maybe we would have thought, oh, a giant lesion comes from this incisors, and leaving us to a wrong treatment. So I think that the end product or the evolution of this treatment is maybe a little bit invasive, but I think we can extend the life of this central incisor a little more. He's going to be restored in a couple of days. So I think it's a good result. Maybe not the most aesthetic, but sometimes we have to remember retreatments are maybe not always the most aesthetic treatments, but they're functional. And I would like to thank you for your attention. If you have any questions, any comments, I would love to hear them. I hope that these cases were a little bit entertaining, and maybe we could have all learned something from each other.
Thank you, thank you. Very interesting and really amazed, and the cases are very perfect and perfectly managed by your skills. I have questions about your cases, but
Yes.
I just want to ask Dr. Atta to start his presentation. We have a good time because you have presented your presentation for about 20 minutes, and we will have enough time at the end of the session to ask our questions. I have written your cases here, and I will ask the question step by step and each case separately. But I want to ask Dr. Atta to start his presentation. Dr. Allen, thanks for your insightful lecture, and your cases were very amazing. We will ask our question and we will learn more from you. Thank you. Dr. Atta, the stage is yours.
Thank you, Ali. Thank you, brother. Thank you, Dr. Alan. Thank you, Dr. Hassan, for the amazing cases, amazing presentations. First of all, I want to ask if my voice is clear, Ali?
It is very good and clear, and
Perfect.
we are ready to hear.
Yeah, let me start sharing. I'm trying to share my screen.
Okay, you are as a co-host and you can start your sharing easily. Yeah, I think we need more than one session because your cases were very amazing and very challenging, and a lot of discussion need to be performed about your cases because the cases are very entertaining and interesting, but we will see how much time we will have at the end of the presentations. Okay, Dr. Atta, I think we have...
Okay, can you
your
see my screen?
Yeah, you need to change it to your PowerPoint.
It's not changed because to the PowerPoint?
No, we have your Zoom meeting actually screen. You need to share your PowerPoint.
1 second, please.
Yeah, no worries.
Okay. Let's see right now. Is it clear right now or not?
It's going to be started, not yet. We have to wait. Let me check. It says it's going to be started. Not yet.
Okay, let me stop sharing and share it again. I'm so sorry for this. I don't know what is happening. Just 1 second again.
No problem. It is coming.
Okay, I think now it is working. Can you double check now?
Yeah, we have it now. Thank you.
Yeah, okay. Okay, thank you very much for this amazing platform once again, Dr. Hassan and Dr. Ali. Having all the skilled clinicians from all over the world is a really hard work that you should be thankful, or we should be thankful for it. My name is Alaa Alatta. I am a specialist endodontist, Syrian specialist endodontist practicing currently in Dubai. I'm glad Dr. Hassan and Dr. Alan has started it, and they made a brief of especially Dr. Hassan in the first slide, he made a brief of the mishaps that we can face in retreatments. Today I want to show 2 cases that myself, I made mistakes in retreating them or while retreating, and at the end we will have a discussion about them. The first case I'll be sharing is for a 47 years old lady. She was referred to me to assess tooth number 26 for retreatment or not. So because the referral dentist, he wanted to place an indirect restoration. So I had to assess, since the patient was asymptomatic, no tenderness to percussion, no tenderness to palpation, and on the radiographic examination, For me, this is a 10 years old RCT, as we can see, that is acceptable. And I said acceptable because back then we used to do single cones with, or they used to do single cones with 2%. And it might been done by a good endodontist with proper irrigation. However, I had a defective restoration over here, and going back to the literature, especially to the textbook of the famous Arnaldo Castellucci, to retreat or not, he has placed a very nice graph. This graph is talking about if you want to change the coronal restoration with a previously done root canal treatment, whether to retreat or not, in a systematic way. For example, he has said that if we are having a radiographically unsatisfied or unsatisfactory root canal treatment, and with a lesion, we obviously go for retreatment. If we don't have any lesion, we go and assess the symptoms of the patients. And if the patient have symptoms, clinical symptoms, we go ahead and retreat. And if the patient doesn't have any symptoms, what happened? Okay, I'm sorry again. If the patient doesn't have any symptoms, we go and we assess the coronal restoration. If we have coronal leakage, we retreat. If there is no coronal leakage, we do not do any retreatment, and we proceed with the coronal new restoration. طيب, if we have a radiographically satisfactory, or we are satisfied about the root canal treatment on the radiographs, because as Dr. Allen has said, white lines or white lies, we never know what the previous dentists have done. And in my opinion, retreating, I always tell my patient that I'm redoing the myths that have been done previously for your tooth. That's why we are retreating, due to many reasons. It might be a patient reason. I don't go and I blame the dentist. Anyways, if we are satisfied about the root canal treatment on the radiograph, we go and see the periapical area. If there is a lesion, we retreat clearly. If there is no lesion, we go into the symptoms. If the patient is feeling pain, percussion, or palpation, we go and we retreat. If the patient is feeling no pain, clinically, we go to the coronal restoration. If we found out there is a leakage, or there is a margin that is open, or if we don't have, obviously retreat. Now, in my case, I had all the red boxes, as you can see. No lesion, no clinical symptoms, but I had this unsatisfactory coronal restoration. So if the patient or if the referring dentist wanted to retreat or wanted to place an indirect restoration, I would rather retreat this case before placing the indirect restoration. Here I started quickly by, these are lengthy videos that I'll not show all of them due to the time, to open the time for discussion. I do a mixture between solvent and without a solvent, like Dr. Hassan. I place my solvent in the coronal part. I start digging with the ultrasonic first, then I insert. Unlike Dr. Hassan, I like retreatment files, but a certain files without mentioning any brand name. Then I introduce my heat-treated rotary files to a certain working length. As Dr. Hassan, once again, he said that we estimate the working length through our preoperative X-ray, and I go short of 3 to 4 millimeters. Then I place my manual files. I do not, in retreatment cases, by the way, mostly I do not rely on my apex locator because I'm not aware or I'm not sure what is happening to the PD space or PD ligament. So I'm not sure if the circuit is going to be accurate over there. That's why I rely on files and on X-ray mostly to take my working length in retreatment. So this was the X-ray when I took the working length of this case, and then I started shaping and I started cleaning. I mostly use hypochlorite in my shaping. I do not go for EDTA gel or EDTA cream. Sodium hypochlorite all the way. And in my final irrigation protocol, I use EDTA solution with activation. And as Dr. Allen has said, that in retreatment, whether we like it or not, we have to enlarge at least to one size larger than the previous size, and we can kind of estimate it in the previous X-ray. Now, at the end, I placed my master cone and I took the X-rays here for the master cone. Now, I put the master cones and I took these X-rays to make sure everything is going well when I removed my master cone, I was placing them on the tray, and I looked back into the patient's mouth, and I saw this fluid. You will see it now, of bleeding and water all over here. See, as if a river, or as if as it was raining inside the tooth, profused bleeding and profused clear fluid that was here all over. See, from the distobuccal canal and from the palatal canal, both of them, see the bleeding continuously. The patient was not feeling any pain, or there was no immediate pain, so I excluded that I might have a hypochlorite accident. But the profused bleeding here made me, or you will see this video is kind of long. I'll see. It is not only bleeding, we are seeing bleeding and clear fluid over here. So it made me get confused. What is going on? What is happening? And it is from both canals, distobuccal and palatal canals. Here at the end, I couldn't control, so I kept on irrigating with saline, irrigating with saline, irrigating with saline, and slight sodium hypochlorite, because I excluded, as I told you, that this is an accident, because if it was a hypochlorite accident, the patient might have been, or might have felt something. And here the patient felt zero pain. So at the end, I wanted to coagulate the tissues, or I wanted to coagulate the bleeding and stop it. So I placed calcium hydroxide and I dismissed the patient. Here is the calcium hydroxide over here. Okay, I'm hearing my voice, Ali. Hello? Ali, can you hear me?
I just
want to make sure that everything is...
Yeah, everything is good. I'm checking. Perfect. I'm checking the voice here. Don't worry about that.
Perfect. Thank you very much. So I placed calcium hydroxide inside the tooth, and I dismissed the patient. Now I wanted to analyze what is happening, and why did profuse bleeding happen. And I went back to the X-rays, because you made a mistake, and you want to know what is that mistake to avoid it in the next session or next cases, as I can say. Now we all learn from our mistake. I firstly went back to the working length X-ray that I didn't analyze perfectly when I took it, and look at the curvature that we are having in the distobuccal canal. We are having a distolingual curvature, as I can say, that I didn't look at it perfectly at the first time. And to make sure with that, I went back to the master cone X-ray to see that I did an apical transportation in this tooth. And I didn't follow, or I didn't go all the way with the curvature of the distobuccal canal that was distolingually, as I said. One more thing, I said that, or you saw in the video, that the bleeding and the fluid was coming out of the distobuccal canal and from the palatal canal. Why did we have a clear fluid? I went again to the second master cone X-ray, and I looked here at the palatal canal and at the connection with the maxillary sinus. Now, the patient, as I said, didn't feel any pain. But in the second visit, surprisingly, when the patient came in, she told me that, doctor, I had some fluid coming out of my nose 2 days or 3 days after the visit. So here, after finishing everything, I'll show you the operation X-ray later on, I started analyzing. I didn't only have perforation in the distobuccal canal, but also I perforated, I don't know if it was the membrane or the mucus or the periosteum of the maxillary sinus. And going back to the literature, this is a very nice position statement by the Journal of Endodontics in with the American Association of Endodontists in 2018, talking about maxillary sinusitis of an endodontic origin. Maxillary sinusitis is an inflammation to the sinus. It can be acute or chronic, as we all know. Now, in my case, it happened because I pushed the debris, I pushed the bacteria, I pushed the microorganism all the way to the sinus, and that's why it got affected, especially with the nose of the patient. Clinical presentation of maxillary sinusitis: nasal congestion, facial pain or pressure, localized maxillary origin. Pain can be higher with percussion or with biting, or even with movement, like any chronic odontogenic periodical infection. The diagnosis can be through the history, through the chief complaint, through the chit chat. These small chit chats that we do with our patients are very important to us. Facial pain, as I said, rhinorrhea, bad odor, bad smell that might the patient smell throughout his daily life. Radiographic examination, of course, CBCTs are the best thing that have been added to endodontics, periapical x-rays to see the relationship between the sinus and the roots of the teeth. Now, maxillary sinusitis can be divided into two things: preapical osteoperiostitis, which is or which appear, as you can see here, as a kind of radiolucent appearance on the CBCT, or maxillary mucositis that can appear as a radio-opaque areas. And these are chronic. These are the chronic parts of maxillary sinusitis in relationship to the roots. As you can see here in the root, we have an infection or we have an abscess. This abscess can lead to this periapical mucositis. Now, in my case, again, it was an acute case. It wasn't a chronic case. And luckily I managed, and luckily I knew the cause. Knowledge is power, or reading is power. That's why we have, as a clinicians, to keep reading to learn more or to update ourselves. The treatment is a normal treatment. Just remove the cause, just remove the infection, which is from the root canal. Do the proper root canal treatment. Antibiotics can be prescribed with anti-inflammatories in severe cases where the patient can have slightly swelling with high pain in the area. But for me, not always recommended, especially that the sinus is located in an area where we do not penetrate it directly through the root. Now, the precautions that we could take is accurate diagnosis and accurate preoperative imaging, which I didn't do, unfortunately. And we all make mistakes. We are not perfect, as Dr. Allen has said. That's why we learn from our mistakes. And I'm showing cases that I've learned from them myself, because if I don't make mistake, I will not be, I will not master the treatments to the patients. Careful measurement of the working length, gentle instrumentation techniques without being aggressive, controlled irrigation, avoid overfilling, anatomical consideration, and special attention to thin or missing sinus floor. Now, in these cases, or in retreatment cases, the associations or the worldwide well-known associations have suggested to take CBCTs always, but in our region, it's not always affordable, because you cannot afford the patient to have a CBCT and come back to you for retreatment, especially if you don't have it in your clinic. Now, this is the final retreatment, and I love single cone technique, although in the palatal canal, I used a hot modified technique to show you, just not to go for a lengthy video. I wanted to fill the perforation, and I wanted to gain the path of the distobuccal canal. Now here, clinically with the files, I could not gain it, to be honest with you. That's why I relied on my irrigation, proper or profuse irrigation with EDTA followed by hypo and proper activation. Then we do the filling, and all the biceramic sealer can go to fill the area. Now, the second case, which is a favorite case of mine, because I'm sorry to, to say that, but I don't like treating kids. A 10 years old girl with her parents, and they are saying there is a ball in my lower left area. The tooth was not tender to percussion test, and in the radiographic examination, as you can see here, we have a large periapical lesion, internal resorption in the mesial root, open apices, both distal and palatal. And due to the open apices, I can say that this is not an optimum obturation, because as Dr. Hassan said in the first presentation, that we should have hermetic seal. We should seal the canals properly. A 3D obturation is essential just to cover up whatever we have done in the first stages, which is the favorite part of mine as well, Dr. Alan, which is the irrigation. When we irrigate very well, when we clean very well, we have to close. We cannot clean our house and keep our door open. it will get dirty again. That's why hermetic and 3D operation is a very crucial part. Now, there was a sinus tract, as you can see here, leading to the mesial root. Now, because of uh, because of so many discussions that I had with the referral dentist, they preferred extraction somehow. Yani, the dentists, when they see this forcation involvement lesion, they go for extraction, especially in the kids, or although it was a permanent tooth. But I said, since it is a kid, I want to try. And I had so many treatment options: regenerative endodontics, MTA plug apexification, calcium hydroxide apexification. The first and the third options and the fourth options were not my options. And I wanted to go with an MTA plug apexification because regenerative endodontics is not so feasible over here due to the large lesion, although some studies have proved that we have stem cells inside the lesion itself. And calcium hydroxide apexification is a lengthy procedure that I do not always prefer, especially with the long application of calcium hydroxide that can lead to resorption if it is over a certain part of time. In addition to all of that, unfortunately the kid was not cooperative. Here I did this case يعني in a way or in an environment that wasn't very convenient or comfortable for me. It was in collaboration with the pediatric dentist we had in our clinic, and we had to place nitrous oxide. I did it in 2 visits, but imagine an uncooperative patient and endo together. That's why I hate treating kids. And it wasn't in my room; it was in a room of like it was designed for kids, where you have multiple screens, and the patient or the kid has to watch some cartoons with these annoying musics at the background, and you hate yourself in the treatment, and you hate endo, and you hate dentistry in such cases. So whenever I see kid in my schedule, I get I have to be calm all the day, and I try to book them early appointments or the last appointments, though, so I can take my time with them, especially uncooperative ones. And it is always with my pediatric dentist. It is never alone, because it is a teamwork for me. I cannot the endo management, especially in such cases. Here I was working with my 3x loops, no microscope, no proper lightening, and annoying music all over. So it was hectic. But at the end, when we see the results, we will see and we will say that it is worth it. Now, this happened when I started. Because I told you that whenever I see a kid in my schedule, I forget to analyze the X-ray properly, and I forget about the difficulties. يعني خلاص, it was an open apex for me, and it was a kid, so يعني, I was only thinking about managing that kid. And I told you, although that in my preoperative X-ray, I saw that I have an open apex, but when I started the treatment, I didn't pay attention to it. And I told you that I love using retreatment files. Whenever I removed the stainless steel crown and I exposed my chamber, I introduced the retreatment files directly, and the disaster happened. And believe me, this was my face when I saw this. So here, in an uncomfortable environment, what I do is I stop working. I place my calcium hydroxide and place my TF, and I stop immediately, because you are not comfortable. The case is difficult. The patient herself is difficult. She is uncooperative. I did not want to make more mess. And kids cannot tolerate dental chairs more than 1 hour. And I wouldn't refer this case for extraction, or I wouldn't do it under GA only for this particular tooth, especially if the patient is not having a full mouth rehab. So I placed calcium hydroxide, and I said, Tara, you need to be more calm, you need to have more time, you need to think more, and refer or put the case in another appointment. So luckily, in the second appointment, the patient came, and I managed to remove everything. The extruded gutta was removed using a mixture of whatever Dr. Alan and Dr. Hassan has mentioned, the XP Shaper or the XP Shaper like files, the hand files, edge files, and those kind of files. Then I placed the collagen sponge. After the placement of the collagen sponge, usually I use Ali, if you can excuse me just for a while.
Yeah, sure. Feel free. Yeah, feel free. No problems. Okay, very good. We have to wait for Dr. Allen to come back here. Okay, I just want to ask Dr. Hassan and Dr. Allen to write their question. Please don't forget about the cases. Yeah, please don't forget about the cases. I'm writing the cases here because we need to talk and discuss about the cases.
I'm so sorry.
I think patiently what
I
you
am
do,
back.
doctor.
Yeah, you are back.
Welcome,
Thank you.
Welcome, Dr. Alaa.
Welcome back.
I am so sorry. Okay.
No problem. No problem.
Okay, let's go back. So as I said, I wanted to do an MTA plug, and I placed the collagen sponge. Now here, Dr. Allen has mentioned, since he has mentioned Marucci products, Marucci MTA
Please
is an
start your
injectable
sharing.
one.
Doctor,
Okay,
I
it's
think you
not
have my
sharing?
voice. No, it's not sharing now. Please start sharing it again. At least I don't have your screen.
Yeah. Okay, I'm sharing it right now. Just give
Yeah,
me a
it's
few
going to be.
seconds.
It's going to be shared. No, not yet. It is gone.
What about now?
It's going to be presented, but not yet. You have to wait. It is loading.
Okay, just give me again.
Yeah, thank you.
Perfect. Okay. Okay, I'm so sorry once again. So I placed my collagen because here I wanted a matrix, although I'm not seeing perfectly under the microscope. And again, since Dr. Allen has mentioned Marucci products, Marucci MTA is an injectable one, a creamy injectable MTA. And here I wanted something very fast because I don't want a lengthy procedure to an uncooperative patient and a patient where I'm almost not seeing what am I doing to her, since I don't have my microscope. I was using only my loops. So I started injecting my MTA. I injected in all the canals, and I wanted to take an X-ray to see if am I really at the apex or not. And I had this MTA spreading all over the canals. So here, a very fast twist that came to my mind, and within few seconds, going back from the screen of the X-ray to the patient mouth, I have seen, or I have went back to the literature all over my mind, and I have said that Dr. Marucci or Prof. Marucci, Prof. Tiroshi, sorry, Prof. Yushi Tiroshi, did a study in 2023 talking about full MTA obturation in retreatment cases. And it is a conventional, he said that it is a conventional alternative to a normal gutta-percha with sealer, especially if it is a mixed MTA, the powder with the gel or the powder with the saline or the powder with the water, whatever. But he emphasized that it is a good replacing material to gutta-percha. So I said in my head that if the MTA that Prof. Yushi has used is working, then the MTA from Marucci should be working because it is a really good MTA. And I went back and filled the whole canal with MTA. Now, to be honest with you, I had slight bleeding from this canal, from the mesial root, sorry. And in my opinion, this bleeding was because of the open apex that I had. But here I said that MTA can release calcium hydroxide on the long term, and hopefully the case will be successful. And again, in such cases, we are trying to do our best, and we are trying to correct whatever has been done by or whatever mess that have been done by previous dentists. And luckily, this was my 12 months follow-up, and this was before almost full healing. And in my opinion, if you can look at the apices of the distal and in the mesial canal, maybe because of the bleeding that I had in the interaction with the MTA, I had some kind of closure, some kind of calcification over there, but I am very satisfied with the result after 1 year with the situation or with the environment or with the way or with the situation that I was working with this patient. This sums up everything. Thank you very much for your attention, and I hope that we will have a good discussion right now, and I hope that you benefited from this presentation. Thank you very much.
Thank you. Very good and very interesting cases. I think the endodontists are the heroes of tooth saving, because the only specialty that is focusing on saving tooth, I think, is endodontics. And this is very interesting because they do all their best to save the tooth that may not be easy to be handled or to be treated. And this is a very good effort. And that's why I really like the endodontics, especially the retreatment field, because in the retreatment field, you do your best. You will do actually many efforts and many heroic actions in order to save the tooth. Although the heroic cases or heroic actions are not acceptable by the literature, because some of them may have not been able to be used in many cases, but I think this effort and these cases will give us the attitude and will give us the insight to perform such treatments in order to save the tooth. Okay, Dr. Allen, if you have any comments, you are free to ask.
Thank you. I would like to point out what you just said, because it's important to that something that I always tell my patients. I'm entering a space that is either contaminated or failing or is messed up, and I'm trying to do my best to return it to a better state. Maybe not the most ideally, because we're graduated on a radiograph. I love Dr. Alaa's last case, because if I would have seen it, I would have said, yeah, short obturation, because we're easy to disqualify by an x-ray. And then you show me this 12-month post-op, and then, yes, it's not all to the apex, but you said reading is power. And the end result of knowing a retreatment is, yes, I'm not maybe achieving beauty, but I'm achieving health. So I think it's very important to explain that maybe to even the general dentist that refers to us. You might not get what you think you're gonna get, like perforation or deviation, whatever, but we have to fix it and work with that. I would obviously rather just do root canals instead of retreating. But it's a complex world that sometimes we think it's easy. Oh, just deobturate it and fill it up, and the general practitioner tells us, oh yeah, just redo it because I have to do a crown. And then they don't know the difficulty that we're entering this world and we have to re-explain everything. Sorry for taking my time. Sorry.
Exactly.
Thanks
Do
for your
the
comments.
best, irrigate well, and the body will surprise you.
Exactly.
Also,
Yes,
there is
yes,
an important thing in retreatment cases. We should consider the patient expectation about the survival and the psychological condition of the patient. Yeah, for sometimes the patient has did RCT 2 or 3 times, and they are trying to saving the tooth. And there is 2 or 3 dentists before me had did the retreatment. So how I can convince the patient that I am one that I will treat? So I do all my best. Irrigate shaping well, irrigate well, and the body will surprise me. Okay,
Very good,
it's really
very good.
interesting.
That's the magic of, and that's the beauty of the endodontics. Okay, I will start my question, but all of you are free to ask your question. I think we have. It's better to start with Dr. Hassan cases. Let me see what are my question. You said you are
Okay,
using XP Shaper and XP Finisher, but in the second case, you mentioned that we are not able to extrude or use the XP Shaper beyond the apex, but you have used XP Shaper to remove the extruded gutta perca from the preapical area. And I want to ask about the effect of using this file, because you may enlarge the apical area and you may have the more large apical area in order to be obturated and to be sealed. What is your idea about removing and actually retrieving the extruded gutta perca from the preapical area?
Body, gutta percha, files, and what else? The most important part, it's that foreign bodies, it's not with the apex level. You can push it outside, it will not cause any problem nearly, or you can retrieve it. So that's the one thing that I mentioned. Not leaving foreign bodies that breaking the seal. And for using, sorry, and for using XP Shaper to retrieve the gutta percha, no, I didn't prefer that. Maybe I will leave that the last option because it will enlarge the apex. It will make a transportation really. If we have a curve, okay, or a canal, it will enlarge the inner wall and making transportation by enlarging the apical constriction not equally, but maybe in one side. So that's a transportation, and you must obturate the canal by MTA. So that's a disaster. That's not correct. So I prefer to be conservative at the first by trying with H file or just pushing the Cotepercha outside. I having cases with 2 years follow-up. I pushed the Cotepercha outside. It was just at the level of the apex, so it's break the seal. So about your question about using XP Shaper, no, I didn't recommend that. Only if you don't have a choice.
Yeah, right. Because actually, as you said, I think the main concern about the leaving such a gutta percha beyond the apex is that gutta percha, we cannot say it is inert because it contains the microorganism, because the gutta percha in the root canal system that was injected and was filled with the previous treatment is not inert and is not sterile or is not disinfected yet. If you push that gutta percha beyond the apex, I think it may lower the success rate of your treatment, but we have to sometimes to wait and to follow up the cases, because if we want to do any efforts to retrieve that gutta percha beyond the apex, we may actually worsen the situation, and we have to leave it to the body and to see what the body is capable of to tolerating or actually removing that source of source of infection.
That's correct.
But we cannot say that it is inert or it is it is good. Yeah. I think the main
outside the body you have antibody. Okay, you have immune system. You can fight, but inside the canal not. So maybe the patient will suffer from flare-up or pain, but not for a long time. What do you think?
Actually,
okay, contain biofilm maybe, but if we extrude it out, what will happen in the future? It will affect on the prognosis? Maybe, but I didn't think so.
I think it may affect the long-term prognosis, but we still have many cases that are successful.
Exactly.
But I think it will lower the success rate. Yeah, to lower the success rate, we have to follow up the cases. Yeah, but you can see, I think it depends on the mass of the gutta percha, because we have articles that says if you have a mass of infection source beyond the apex or in the periapical area, the amount of the gutta percha that is extruded may lower the situation. And
Bro,
my
that
next question.
extruded, it's talk about extruded gutta percha, and that's or overextension gutta percha. That's not pushed completely outside the apex. They are talking about gutta percha that's breaking the seal.
Oh,
Also, there is
yeah.
another articles that talking about
Yeah, you're
the
right.
survival rate between the over extruded gutta percha and overextension or overfilled the
That's different.
or under obturation, sorry, between the under obturation and between the overfilled. The overfilled have more success rate, so it's not about the material that pushed outside. It's totally
Eh,
about the seal that you shape it all the part of the canal that you disinfect very well, so it will survive. And we have, I and all of you have a lot of cases, and you see a lot of cases.
Exactly.
For example, I, I faced a patient with upper canine that have extruded gutta percha, 4 or 5 mm before 7 years, and the neighboring tooth, it was a 4. It have also overextending gutta percha, but it fell. Why? Maybe the first one. Okay, it's multifactorial. There's not only one thing, but it just maybe about the seal and the canine having seal have overfilled, and in the 4, no. It's just extension. There is no seal. Also, it depends on the is the tooth was vital or was necrotic, the amount of
Exactly.
bacteria, and there's a lot of factors.
Yeah, you're right. Thanks. I remember when I was at my residency program, one of the masters has the technique to actually dissolve the gutta percha that was extruded beyond the apex. And that technique was using the chloroform and try to push it beyond the apex and try to have a chloropercus solution and then remove that chloropercus solution by using a paper points beyond the apex. But I want to ask you all the actually endodontists and the guest speakers to talk about this technique. Is it good to use chloroform or any solvent beyond the apex in order to remove the gutta percha which was extruded at the apical area? At least in my opinion, using the chloroform, especially because of its toxic and its carcinogenic reaction and feature, it is not reasonable to do such technique in order to remove the gutta percha. Yeah, Dr. Allen, go on if you want to talk about this.
I would like to talk a little bit about that because I personally do use solvents, but I do not use Hilol or any of these carcinogenic ones. I actually use one that's citric acid, which is actually orange based. So it's based off a fruit. It has 0 carcinogenic effects if you extrude it. The manufacturer actually tells you can irrigate the apex if you want. It's not going to do anything, any harm to it. I mean, don't do it, but you have this security that if you do extrude, you have no potential damage to it. And I would also like to point out 2 things that it's really important and that do remember what we're dealing with every day. One with Dr. Alaa, that if he would have shown me this first x-ray of the child, I mean, I would have maybe thought it's a child because of the x-ray, but it's not the same doing it on even if in a kid, but that gives you a wide opening and behaves and you can do everything on your clinic. Then on this uncooperative situation, you're irritated, then we start changing, because it's really easy for us to say, well, why didn't you do a apical plug? Well, yeah, sit down and do it on this, I want to say on this fierce or violent environment, you know? And the other one would be, we obviously have our journals and our literature, and we say, don't extrude, don't do this. But like Dr. Hassan said, we're dealing with a body. We're dealing with the host. How many times haven't we seen 7 millimeters of extruded gutta percha, and the patient has been asymptomatic, lesion-free, 30 years. And our most beautiful root canal done, and it hurts. And I did by the book everything. So I think it's good to have a well-established protocol, but also remember of the host, because I've had these cases of extruding gutta percha, and I haven't been able to retrieve them, but I take the post-op and nothing happens. No lesion, it's encapsulated. It doesn't mean just go ahead and throw everything away, but also remember and give space for the body to heal.
Very good, very good. That's exactly. At least I do not try more attempts in order to remove that remnant of gutta percha, because we have seen that in the history of endodontics. We have apexome, the instrument that were designed in order to disinfect a periapical lesion, but that was not successful. And we know that any instrument or any actually extra effort in order to disinfect the periapical area is not mandatory, and it's not reasonable. We have to leave it to the body to see what's happening in the future. Okay, I don't have any question about the Dr. Hassan's cases, but I just want to ask you if you have any question from Dr. Hassan about his interesting cases. You are free to ask. Is there any other question?
Yes.
I have
Thank
a
you. Thanks
question,
for-
Ali, Dr. Hassan.
Okay,
If
before
you please
we
allow
talk,
me. Dr. Hassan, you have placed the MTA in the first case I'm talking about. You have placed an MTA all the way to the working length, and as you said, I am not against over filling or not overextension, but overfilling, as I can say, but the overfilling of MTA. I'm curious about knowing what was the size of the apical part of that tooth. Why didn't you go, for example, for bioceramic with a single cone? Just to open up a discussion.
okay. As you know, the literature said when you face apical diameter more than 50, okay, it's better to obturate by using MTA to get a perfect seal. So before the size of 50 or apical gouging 50, you can obturate with a single cone and bioceramic sealer, and you are trusting you get a good seal. But for more than 50, no, I didn't think so. Maybe if you are using by cutting the perche and making size, mimicking nearly the apical diameter and using bioceramic sealer. But are you trust with that? Are you sure you are having hermetic seal? Of
For
course
me,
not.
not. I trust your.
Course not.
I
So
trusted your judge, but I opened this question because I get it a lot, by the way, when I do apical sealing with almost 50 or 55 apical size. Doctors or the referral dentist asked me, why didn't you go for bioceramic sealer? And since this video is going to be for all the dentists, that's why I'm asking you this.
Exactly. Some articles say it's 60, more than 60,
Yes.
and some articles say 50. So it's better. It's really easy way to you can obturate by using injection the MTA and using the gutta percha as a plugger. You'll get
Yeah.
MTA plug with the easiest way. I don't prefer using powder liquid. It's really really difficult, but you can use it. You can handle it by using rotary MTA carrier or placing directly into the canal or using rotary file with the reverse motion with the 300 RPM by making the flutes packing the MTA directly outside. But
Yes.
for me, I am lazy dentist. I prefer the putty ready-made.
Yes. 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 It's made for making our life easier at the end.
Yes.
Yeah.
And the dentist love the easiest way. All the
Yes.
dentists
You're all
love it.
looking. Yeah, that's the point and the goal of the actually technology. We want to have easier life, so we are looking for easier way, and that's
Exactly.
reasonable.
Exactly.
Yeah, that's reasonable.
Yes.
When you have putty, why you have to go for old MTA? Yeah. Very good.
That's,
Okay, I want to ask my question from Dr. Alan Cases, but this question is a general question, and I want to ask you, do you use ultrasonic or sonic activation when you use solvents? Because I think we can use ultrasonic activation in order to remove the remnant of gutta perca in isthmuses or in inaccessible areas. But there are some concerns about extruding the solution beyond the apex. And I want to see if you have any article, if you have any evidences in order to use solvent, because we know that we have wicking effect at the end of the retreatment. I think Dr. Hassan has talked about that wicking effect when we want to be sure about that we have completely removed the gutta perca or any filling material inside the canal. We can use wicking effect, but I want to ask about the activation of the solvents.
I personally don't activate the solvents. I do a two-step placing. I don't use retreatment files either. I used to like them a lot. Suddenly I lost interest in them. I do use rotary files, regular for saying some I don't know, Pro Taper Gold, which are big tapered. But I would use a two-step. I would flood my chamber with a cotton pellet filled with the solvent, leave it there for, I don't know, 30, 40 seconds. And then this coronal part of the gutta percha is gonna soften up. Then I can introduce my rotary file and start retrieving the gutta percha. If most of the time, 90% of the time, that's enough for me to fully retreat to the apical length. If it's that hard enough gutta percha with the sealer, I would do a second application, but I'm never actually reaching the apex with the solvent. Most of the times when I do a second application on the middle 1/3, I would go directly to apex, and once I retrieve my my file, it comes with the full tip of the cone. So I never reached the necessity of irrigating or activating it. Any leftovers of the gutta percha, I have H files for that. So I believe I'm being a little bit more conservative and not activating or not extruding any of the solvent. And I have the advantage that if it does happen, it's non-toxic, the one that I use. So it gives me a little bit more safety on that area.
Very good, thank you.
Dr. Ali, I have a question.
Yeah,
Do you
sure.
have any article that say that the orange oil is a toxic material if it's go outside? Or is its material toxic? Because as we know Dr. Yushi use chloroform, not the orange oil, the chloroform, and inject the material outside the apex. It's really not reasonable. Just leave the material outside. Uh, that's my opinion. But he is great dentist. Okay, and we are learning from him. And he say, just inject the material, inject the chloroform outside the apex, and using paper point to pull it. What do you think? What do you think about the toxicity from the biological point of view, or the carcinogenicity of the material?
Yeah, in my opinion, it is not reasonable to do such thing in order to remove the excessive material or any gutta perca. I do not do that. I don't have any experience with any materials like that, but I just use chloroform at the end of my retreatment cases, but I don't do such things in order to
Is
remove
there
the
any
gutta
article
percha.
mentioning that? Is there any article I mentioned
I
that?
haven't seen that. Actually, I cannot say by sure, but I haven't seen that. Okay, any other comments about this question, or we can go for the next question. I have some comments about. I have some comments about the case. Yeah, the Dr. Allen shared. I really amazed by the case you shared. Your first case was about the pain, and your presentation about the pain is, I think, is very important, because we have to consider that not all the pains come from the odontogenic or endodontic sources. We have to consider non-odontogenic sources, and your case was a very good case to show that it is very important to completely check and to see the patient history, to see the dental history of the patient, and do not have the tunnel vision only on the endodontic treatment very actually specifically. And the case was very interesting. And your second case was about two separate lesions, the nasopalatin cyst and the endodontic lesion. And about the ordering the CBCT, I want to ask you, why did you order the CBCT intraoperative? You were not, weren't you able to be sure about the perforation when you have, for example, two periapical radiograph from two different angles? You can say that, okay, I have the perforation. Why did you order the CBCT intraoperatively?
Okay. Yes, I definitely deducted that with more x-rays that it was perforated. But remember, we have a two-dimension on a regular x-ray. I do not know if it's lingually, if it's palatal, if it's buccal, if it has a certain orientation, or if it's too damaged for me to actually repair it. So I think it's important to enter knowing what you're going to enter too. I had the advantage of ordering the scan. Even if I suspect of going surgically, which I thought that it would be a possibility, and I let the patient know, I always order a scan. If I have the suspicion that I'm going to do something surgical, I never enter without a scan. And it actually helped me out because, one, I would have thought that the original canal was easy to find and just go through and repair it. The truth is, it wasn't. So that can only be shown with the scan. It's just being cautious. I gave this patient option 1, 2, and 3. One option was, yeah, extract it because you have a problem in there, but we don't want that option. So the one would be repair it without a scan, and I'm not knowing what I'm doing really because I'm going in blind. The second one, retreating with a scan and maybe going surgically. And then with the scan, we know and we verify that we have to go in surgically. And the cyst was just a chance that we found. I didn't enter there knowing that I was going to find the cyst.
Exactly. I asked that question because I want to see Dr. Hassan and Dr. Atta about ordering the CBCT. I'm the fan of CBCT. I'm the fan of ordering CBCT. When I face any challenges, I prefer to order the CBCT. We can, in that case, I can't be able to say that it is buccal or palatal, because using the Clark's law or using the Eslambol law, we can still say that the perforation area is at buccal or at the palatal part. But I want to see exactly what's happening in three-dimensionally, and for especially for the nasopalatin cyst, for the cyst that it is not related to the tooth, because in the CBCT planes you can see that we have completely two separate lesions, and the palatal cyst was not related to the tooth, and it helped us about the final diagnosis and the accurate diagnosis. But I just want to ask Dr. Hassan and Dr. Allen about ordering the CBCT. Would you order CBCT in that situation?
My dear friend, nearly you can manage the cases with the two-dimensional X-ray by taking different view, same as all, the same lingual, the opposite buccal, okay, SLOP, and reading the X-ray from different view, from the buccal, from the lingual, from different size, and collect all the data to making three-dimensional image. But it's not enough, especially for retreatment cases, especially if you faced a good RCT, it's good white line, good filled, dense obturation, and it's filled. Why? So the CPCT is a must here, and you will surprised. You will find a lot maybe of mishaps. You will find a lot of missed canals, or there's maybe crack. So in retreatment cases, I prefer to order CPCT, not for all, but if it was good RCT, I will order CPCT. There's no choice. But if it's bad, if it's under obturation or it's obvious there is a missed root here, of course, I will not order CPCT. Okay.
Yeah, I think the CPC can be different, and it's a separate title to talk about, because we have a joint position statement about ordering the CPCT in different situations. And in that joint position statement, we have that we can use and order the CPCT in retreatment cases. I have seen a lecture that was from Dr. Shannon Patel, and in that lecture, he said that he's ordering CPCT for each of his cases. And I was really impressed by that, because we do not have evidences and literature to support this, but he orders CPCT for every of his cases, because he has seen that in many cases he has seen and seen the actually challenges and seen the points and the details that were not able to be seen by 2 dimensions radiograph. Dr. Atta, what is your idea about ordering the CPCT? I want to have your opinion.
I've mentioned, yes, for sure, Ali, thank you very much. And I've mentioned in the presentation that nowadays, ordering a CPCT, especially if you don't have it in your own clinic, would be a little bit costly for the patient, as you have mentioned. In retreatment cases, I am a fan of CPCT, especially with the new technology, new machines that have the limited field of view with the minimal exposure, which we were afraid of before, that radiological exposure of the patient or high radiation to the patient is not essential, especially if we don't need it. But as you said, in all retreatment cases, in my opinion, following some kind of literature or some kind of the joint position statement that you have said, CPCT is indicated. But can all of the patients afford it? Can all of the clinic have it? I'm not sure. For example, in one of my clinics that I'm working in here, we have CPCT. I requested, even if I'm not going to charge the patient for it, I requested for my own. If the patient is later on needed to go to another clinic, have another opinion, etc., and he wanted the CPCT, I tell him you have to pay for it, because at the end of the day, dentistry is a business, and I'm not an owner for a clinic, and we cannot keep aside the talking about money, in my opinion. So yeah.
That's exactly, because nowadays we can say that every CPCT scan, especially with a limited field of view, is equal only to periapical radiographs. And yes, we can say that there is no concern about the exposure and that's effect of exposure, because it is just equal about 2 parallel periapical radiographs. And I want to ask you about your countries and about the law of your countries. Can you have CPCT device at your office or at your dental clinic as endodontist? Because I think in some countries, for example, in UK, we have that permission that the endodontist can have CPCT devices at their own office. I want to ask you each to talk about this. Dr. Hassan, you can start.
Yeah, since I'm already talking, let me tell you about Dubai, for example, or about UAE. If you get the approval, you can add whatever you want. There is a certain, what I can say, a part of the government where you have to take an approval for a CT scan or even for the panoramic X-ray, where there is a certain, as I can say, a certain design for the room of the X-ray that you have to do to be able to put that it's supported by lead and or steel, and it has to have all the precautions that there is an X-ray or there is an X-ray machine inside the room over here. So certain rules are there, but once you get the permission, it's totally fine. You can get it here in any dental office.
Unfortunately, we don't have that permission in our country because of the conflict of interest, and the radiologists and their association wants to have CBCT exclusively for their own specialty. But I think the world is changing, and the endodontics can afford having CBCT in their own practice because it is not that hard. And I have many actually cases when I refer the case to the radiologist. Finally, I have to see the CBCT by my own because the radiologist doesn't have that attitude and insight like us to see the details that we want. For example, many radiologists may say that we have vertical root fractures, but when you check the CD or when you check the DICOM file of the CBCT, you may say that no, it is not the vertical root fracture, it is just a simple parapical lesion, and that's the dilemma between the insight and the attitude of the radiologist and the endodontist. I think endodontics can work better with CBCT in their field of specialty, in their field of endodontics. Okay, Dr. Hassan, what is the law of your country, Iraq?
It's like Emirate. If you prepared the special room, let it walls to contain all the X-ray. So it's okay. After taking the permission, you can bring the CBCT and work with it. But I don't prefer that really.
I
Okay,
think we
because
can.
it's so costly. It's so costly machine.
Yeah,
If you want to take a CBCT, you must taking the good one, the best one. If you have endodontist, you need a machine that support that, and there is maybe only one or two machine with $100,000 price. So I
yeah,
prefer
that's
to
the
get
matter.
a gentle way instead of taking CBCT. I think it's better.
Yeah, that's the matter of price. But I think it will help us in the long term by the cost and by the fees that we take from the patients.
Maybe,
Maybe, yeah.
But as I told you, not all the patient need CBCT.
Yeah.
Only the
Okay,
retreatment.
doctor. Yeah,
Uh,
exactly.
I place myself instead of the patient. Why taking a CBCT and taking extra fees from the patient for a case it's obvious failed because it's under or there's a missed canal? Why? For
Yeah.
that reason.
Thank you. Dr. Allen, what is the law and the rule of your country, Mexico?
There is some noise on the clinic. Can you hear me good?
It's good.
Yeah, we can. Yeah, it's good. We can hear you.
I think it's basically what Dr. Alaa is saying. It's not a permit per se that you have to get in Mexico, but you do have to follow up where you're going to place the machine with the walls and the signs and everything. But it's basically free sale here. Like Dr. like Dr. Hassan just mentioned, it's a costly machine. But I think each year we're globalizing more. I remember when having a digital X-ray was the top of the line of for endodontists, and it was a $7,000 machine. You know, now you can get them for 1,000 or 2,000, and it's evolving with time. Same with as microscope. Only the most wealthy
Exactly.
endodontists will have a microscope, and now everyone has the most open access to them. I think it's just a matter of time before they get a little bit more accessible. But as Dr. Hassan said, if you're gonna get a machine, get the good one. But also, if you're really gonna use them, then you have to get them. If you place implants, it's good to have them. If you have a full clinic restoration, it's good to have them because you're gonna reimburse your investment. But in my case, I would rather, for the time, just there's a radiographic center 3 blocks from my office. So I just send them off and have them send them back here.
Very good. Thank you. Thanks for your comments. I have only one another question. It is my final question, but you are free to ask any other question about the one visit or two visits retreatment sessions. Because we know that we have articles and we have papers in the literature that there is no difference in the success rate in the matter of having post-op pain in about one visit or two visit retreatment, but there are still some endodontists and some concepts that say that you have to do retreatment in two sessions. I want to ask you about to talk about this idea and about this concept. What is your criteria to do retreatment in one or two visits? My actually concept is the same for all the teeth. If I can be able to actually completely dry the root canal and there is no pus or there is no persistent drainage through the root canal system, I will go for the obturation in the single visit. But I want to see your concepts.
Bro, if you get dry canals, you can obturate. That's the rule. But if you read in books, they say you can obturate if you get dry canals also without sign and symptoms. Because if you obturate canals, if you obturate for patient with pain, this pain came from pressure. So if you obturate on the same visit, this sorry, this pressure will increase. So the patient will suffer from more pain. Maybe some dentists say, I will give him a painkiller and that will be
Exactly.
in. But really, I don't prefer that, especially for some type of patient that I know them, they can't withstand the pain. So for such patient, I just place intracanal medicament to making a relief room, not to close it completely. And that's my opinion. But in general, if you get dry canals, you can obturate. And that's our rule. Also, for retreatment cases, I prefer to placing intracanal medicament to because maybe there will be flare up after the next days. So I will not close the canals. Also, as I told you before, making a room, making a space for the fluid that will happen in flare up in the severe inflammation stage. Okay.
Yeah, exactly. Because we have an systematic review. We have a systematic review at the JOE, and in that systematic review, it was mentioned that the rate of the filler up after one visit and two visits retreatment is equal. We cannot say based on the literature that there is difference between the rate of the filler up in one visit and two visit. But I have the experience that doing some cases in one visit may have more flare-ups and more pain at the post-op.
Bro, I didn't mention the difference between flare up between the one visit and multiple visit. But about the pain if there will happen flare up. If you close the canals, the patient will be in pain more. That's
Yeah,
the point.
I have had that experience. Yeah.
Also, really, I faced flare up very little. I don't face this problem. It's only in, especially in retreatment cases, I didn't face that because I follow a protocol for retreatment. It's start from aeroprofy the tooth before entering the canals and removing all the carries, removing all the coronal part material and irrigate while heating the sodium, activate it. Then start with the crown down technique, remove all the coronal part of gutta percha, irrigate while activate, heating, then entering the middle part. Then finally I leave the apical part, okay, to getting the patency and I removed all the debris, removed all the bacteria above this area, so I will not face any flare up. because the flare-up, as you know, it comes from extrusion of debris or biofilm.
Exactly.
So exactly that's the defense mechanism of the body. So
Yeah, all the procedures you said will decrease the chance of the flare-up at your treatment.
exactly. Maybe from 20 patients, you will face one patient, and that patient is immunocompromised. Okay.
Very good. Thank you. Thanks for the comment. Dr. Allen, what is your idea about one visit and two visits retreatment?
I think I'm on the same page with Dr. Hassan here. Most of the time I do single visit if it's feasible, if it's doable. If I have obviously suppuration or something coming out of the canal, I'm not gonna obturate on that single appointment. I do have some, I never call it a justification, but I do a lot of times like to explain my geographical stance in my country. We're borderline with the United States, and 90% of our patients are US patients that come over to our country to get the attention. And it's not as easy for our patient to just, oh, I'll see you in 2 days so you can finish the obturation, because they have a 3-hour, 5-hour, 12-hour drive for them to then get to the clinic, cross the border. Sometimes crossing the border is 6 to 8 hours. So add this up, the patient is not wanting to come back. Or sometimes they have to fly and come to our clinic and then fly back. So we have to do our really best to try and finish most of the times in a single visit. So we have to be really and extra careful with all the procedures. Definitely, if it's something that I cannot finish, I will not finish, and I will let the patient know you're gonna flare up or you're gonna have really bad consequences if we finish it up right now. Definitely. Most of the times I do send them with painkillers because it's not as easy for me to control that patient outside. And even if I give them a prescription, they cannot sort it in their country. They have to do it here and take it with them. So sometimes it's the geographical stance of we have to do it well, quick, and in a single appointment, because it's hard for us to have this patient again. I'm not sure if you have this type of situations in your country, but it's really rare for a patient to, oh yeah, I'll come back tomorrow. It's really, really hard. Or they have to plan out their visits with us because they have work, traffic, everything. It gets really crazy on these border towns.
Thanks, Dr. I was surprised about that. So it means that the price of the endodontic treatment is cheaper in your country in comparison to the United States.
At least 4 times cheaper. And a
Wow.
lot of times I do consider even better.
Very interesting. I didn't know such fact about the price and different price of the endodontic treatment between these two countries. Very interesting. Thanks for sharing your knowledge and experience. Okay, Dr. Allen, what is your idea about one visit and two visit treatment?
I think Dr. Hassan and Dr. Allen has mentioned almost everything, but I want to emphasize on one more thing, which is the removal of the operating material. Like, I'm not sure if you have ever experienced trying to remove Russian wax material, for example. Oh my God, like for each canal, we might need around 20 minutes for each canal. Very solid material, very tiring material to remove from the canals. So even sometimes you have an upper molar with all those Russian wax, where and sometimes some dentists, or back then, they used to mix between Russian wax and gutta-percha, where they put the gutta-percha in only 2 to 3 millimeters of the coronal part of the canals, and you take your X-ray and you see only gutta-percha, because the wax or the resin material as well, it doesn't appear on the X-rays. Once we open the canals, you start seeing those red areas where you start counting how many minutes you need for each canals, because it really takes time. It is a very hard material to be removed. So in addition to to whatever Dr. Hassan and Dr. Alan has mentioned, yes, single visit and 2 visits, according to literature, post-operative pain, flare-ups, etc. It doesn't have many differences as long as you are having dry canals. But in addition, as I can say, removing the gutta percha or taking time in removing gutta percha can sometimes control your decision in single versus multiple visit retreatments.
Exactly. Thank you. Dr. Ahmed, I think you wanted to say something. Go on if you want to add any comments, Dr. Allen. You just want to say that you have the experience of having faced with Russian red or such.
I have had 2 cases of Russian red, and it was early on when I was recently grad endodontist. And just like Dr. Ala said, that I was actually an Ukrainian patient that arrived to our clinic. My first experience was just as he mentioned, 1 hour for the palatal canal. And I didn't achieve full working length. I did my best. And the second one was, I couldn't even get past it. So those are the cases that I would go, you know what, let's just hope this tube survives because of the materials that I use. And it's these cases that you read about these materials and you think, oh yeah, I'm able to get rid of them. But if sometimes we're not able to get gutta percha out, just imagine Russian red. So this is like the difficulty of retreating. That's what I would consider.
Exactly.
Exactly. It's like the war.
Thank you. I haven't experienced to deal with Russian red yet.
I hope you will not.
Let's hope you never do.
Yeah.
Dr. Alaa,
Yeah.
you said something beautiful about the gutta percha. Not only the Russian, but sometimes we face the retreatment cases, but gutta percha is radiolucent. It's not radio opaque. You faced
Yes.
any case like that? What do you think the cause? It's the brand of the gutta percha that the previous dentist used. It's radiolucent, it's bad quality, or what time when there is abscess or there is acidic environment, the radio opacifier material in the gutta percha has been removed. What do you think?
To be honest with you, I have faced such scenarios where, yes, as you said, we see some gutta percha, as I told you in the coronal part, then you enter, you either see Russian wax or you see gutta. Very nice point to mention. Thank you very much. As you said, maybe from the acidity of the inflammation or the infection, or maybe of the branding back then, or the way that the gutta percha was produced, especially if it was a very old case, more than 20 to 30 years old, where the body kept on dealing with this foreign body, because at the end, gutta percha is not a bioactive, it's an inert material. So yes, I totally agree with you. Thank you very much for mentioning.
That's the answer for dentists that say the macrophage eating the gutta percha. Really, the macrophage will be eating the radio opacifier material of the gutta percha and not eating the gutta percha. So it's on the X-ray. It's obviously removed, but really not.
I have had the same experience, but it was about the fake gutta percha in our country, because we have some brands that are not reliable, and those gutta percha from those brands are actually radiolucent, and we have that same issue, and you can see that radiolucent area immediately after your final obturation. And you may think that, I don't have any gutta percha in the root canal system, but because in our country, we will say that the gutta percha is completely fake, and you have bought a fake gutta percha. But I haven't seen that, as you said. It was very interesting for me. Very good, thank you. I think this topic and the discussion is very wide, because there are lots of titles and lots of points, and I think we have to have to have longer discussion about these topics. But I just want to ask you if you have any other question or any final comment about the cases or about anything. Feel free to ask, and I want to finish the session in a few minutes. Dr. Hassan, if you have any comments or if you are,
No,
you
thank you so
can
much
say.
for inviting us for these this great webinars with this great dentist. Thank you, Dr. Alan. Thank you, Dr. Alaa, for this great information and presentation.
Thank you.
So,
I would like
Thank
to
you.
thank for the opportunity and to share, and even if we're in different nations and different cultures, we kind of agree on the same terms with certain differences, but
exactly.
dentistry is the same here and in the moon. So I believe that we have the same problems, the same frustrations, and we can agree on most of the things. And I find that really interesting. And the difference of opinions is what makes our knowledge grow, because if we agree on everything, we don't learn anything.
Yeah, exactly. Thank you.
Exactly.
Yes. I would like to thank as well everyone, especially Dr. Ali, Dr. Hassan. You are doing great efforts. We really appreciate it. Having these free webinars, free platforms for all the dentists worldwide. I'm grateful for it. I'm grateful for the opportunities. We are meeting only in huge occasions, but nowadays with the social media, with the networking, we can.
Exactly.
Dr. Alan is in Mexico, and we are in Middle East, for example, and we are connecting easily. So thank you very much for this opportunity as well.
Special thanks
thank
for
you.
Dr. Hassan, the warrior
Thank
that
you. Thank
worked
you.
behind.
Actually, we have Dr. Pariser here. I want to ask her if she has any comment or anything. She can open his camera and his microphone to talk with us. If you can hear us, Dr. Pariser, because we will have her in the future programs. Dr. Pariser, are you ready to talk about or not? I think she may not be able to talk. I will wait a few seconds and then I will go on. Okay, there is no reaction from her account. Maybe she cannot hear us. Thank you. Actually, thanks, Dr. Atta, for your actually kindness and for your generosity
Dr.
towards us.
Ali, why you say that I can't hear you? I heard all of the things. First, I want
Very good.
appreciate
Thanks.
Dr. Hassan, Dr. Alaa, and even Dr. Alan, and even you done a
Thank you.
very good job. It was very useful. I heard all of your speaking, whatever you said, whatever you discussed, and the opinions about the retreatment cases. I was all of the time here next to you, but my face, sorry guys, I'm not in a good condition. I can't share my face, but my voice is for you. And I had a very good time. I'm so happy that we are from different countries, but me and Ali are from the same country, but others. I appreciate the time that you give us, and I hope that we will have a very, very beautiful and fantastic time in Endo Leaders show with each other. I'm here next to you. Don't worry.
Thank you. Thanks for your
Thanks.
comments. Thanks
You
for
were
being with us.
Yes, but sorry, just I want to say something, guys. We don't have Russian red in Iran. Because of that, we don't retreat it, and we don't care about the time. This, I think, is a very good thing, because I heard that even one canal would take 1 hour, and I'm so happy that Russian red is not in Iran. Just I said that for fun.
Thank you.
I
Yeah,
hope
exactly.
yes, I
We are
hope
lucky.
that
We are lucky, Parisa, because
yes, we are
You
lucky.
are
Yes,
lucky.
of course, exactly.
My God,
But
lovely.
I enjoyed
God
the
mercy.
cases that you shared with me. It was very fantastic. I hope to see you eyes to eyes, not just in internet, just in Zoom or Instagram. You are all our friends, our family, and I hope to see you in a very soon time.
Thank you.
Thanks.
Thanks for
Thank you.
your comment and for your dedication, Dr. Parisa. Thanks for being with us all the actually during the webinar. Okay, I just want to thank you all, Dr. Hassan, Dr. Atta, and Dr. Allen, for accepting our invitation. I'm doing this job with the help of you guys because this project is not accessible and cannot be successful in the future without the help of each of you. And we are working on this platform to be spreaded and to be shown to all the endodontists and to all the dentists and to all the dental students in the universities all around the world. And we think we can be a big community in the near future. We will have big projects. We will have actually bigger discussions, and I'm sure that we will meet each other in the near future in the different parts of the world. And there is no boundaries actually because of the media, because of the social media, and because of the technologies we have. And thanks for your dedication and thanks for your generosity to sharing your knowledge free on this webinar. And thank you for this amazing session. I'm sure that this session is not enough to talk about all the details of the retreatment challenges. We will have such meetings in the near futures about the retreatment, especially because the retreatment is a wide field in the field of endodontics, and you will face anything in the retreatment cases. And retreatment cases are, I think it's completely unpredictable. When I have a retreatment in my daily practice, I will tell the patient that everything is unpredictable. I just have to start the treatment, and I will inform you about the long-term prognosis during the treatment or maybe at the end of the session. You may have the cases that you will say that you have to actually change the treatment plan during the treatment. And that's why the retreatment cases are very challenging. Thanks for your actually cases, for your amazing cases. This session will be shared on the YouTube and also on the on Instagram, and all of the actually participants and audiences will see this session in the future. Okay, this session is finished. I'm very happy that have the chance to hosting you here at the 7th session of the ELS program. Looking forward to meeting you in the future programs. Have a good time at your countries with your families and with your friends.
Thank you
You
so
too,
much.
Thank you.
Haji. Thank you
Thanks.
very much.
Have a good time. Have a good times.
Have a good time. Thank you. Thank you.
See you later in the next
See you
project.
later.
See you
For the
later,
next,
brother.
yeah. See you later. Take your
See you.
time and enjoy your
Pleasure
time.
seeing
Have a
you.
good night.
My pleasure, my honor. So it was a big honor for me.